going to be where the body attacks the immune system. Most people have heard of lupus, but there are a variety of these disorders. And these are not nearly as common as allergies with secondary infections. But you will, if you're in a busy small animal practice, you'll see probably one or two of these cases per year. The way to recognize these is that 90% of dogs are going to have the nasal planum, pinna, and pad pattern. And it's not just having crusty foot pads. They need to have a combination of the nasal planum, pinna, and pads. And then they can also have weird patterns. The other 10% in dogs may have a total body crusting disorder or large areas of erosions and ulcers. We talked about in cats, it's much more typical to see the perinipular dermatitis. So, crusting alopecia rash around the nipples up and down the cat's chest, whether it's a boy or a girl cat. There are pretty cookbook diagnostics. The big major diagnostic test would be skin biopsies. And it's much more accurate if you use a dermatohistopathologist, a pathologist that has a special interest and special training in skin and dermatologic conditions. The problem is that it's difficult to access a dermatohistopathologist. So here's a biopsy practice out of Florida, and they do a pretty good job for general practitioners. Okay, we have several diseases. The most common by far is pemphigus foliaceus. We also have bloody diseases like bullous pemphigoid, pemphigus vulgaris, and systemic lupus. And I'll show you pictures of these. And what differentiates these diseases is not only the clinical appearance, whether it's a superficial crusting disorder or a deep bloody ulcerative disorder, but the protein that's being attacked by the body. So where the protein is in the body and where the protein is in the levels of the epidermis and dermis is going to determine what pattern we have, planum, pinna, pads, but also the depth of the lesion, whether it's a crusty or bloody presentation. They're fairly rare. In veterinary medicine, most of our autoimmune diseases are categorized as primary or spontaneous. It's usually middle-aged female dogs are most predisposed, and there are a few breed predilections, but sort of middle-aged dogs is a more useful parameter. In humans, there are a whole big variety of secondary or induced autoimmune diseases. For instance, if you're in a car accident, a lot of your self-proteins get exposed to the immune system and you can develop lupus. I'm convinced that part of the whole post-COVID infection syndrome is a type of sensitization and almost lupus type reaction where you have vasculitis and sort of these chronic syndromes that we might associate with systemic lupus. It's not identified and diagnosed as a lupus, but it certainly seems very, very similar in its clinical presentation. That would be sort of like the long COVID type symptoms. And then, if you remember from the very first lecture, the way that the skin is put together and how it sticks itself together from cell to cell or from epidermis to dermis through the basement membrane zone is through unique proteins that really function very similarly to Velcro. So one cell type will have sort of this big giant protein that's anchored in the cell membrane, and then it's going to interact with another protein either on the basement membrane zone or on another cell, and that's going to adhere the two together. And then when the body attacks these proteins and damages them is how we end up with the clinical lesions and symptoms that we can recognize. This is just a fancy microscopic, fluorescent microscopic image showing these protein Velcro bonds that are going to be the target of autoimmune disease. Different proteins are affected and are represented in different layers. And so pemphigus foliaceus is the desmoglein 1, and you don't need to remember that. But just remember that depending on the protein, that's going to tell us the clinical pattern on the body, but also the depth within the epidermis. Some of these have been named pretty well, at least memorably. Desmoglein 1, not so much, but bullous pemphigoid is a deep bloody disorder. And the protein that is attacked there is bullous pemphigoid antigen. So that's very nice and easy to remember. And then you can do this kind of a chart. So how frequent the disorder is, pemphigus foliaceus and discoid lupus are the most common in dogs. And then which protein is being attacked, and are we going to have lesions in the mouth? That's fairly rare. Are we going to be sick and ill, like with systemic lupus that can affect the kidney and bone marrow? And then are we going to have scarring, or is it going to be a deep bloody disease or more of a superficial disease? Again, I don't expect you to know this for an exam, but this would be the type of thing you would be expected to know during a dermatology residency program. And this is just a nice representation showing that we have the little proteins and the Velcro structures between cells, but also between the cells in the basement membrane zone to hold the epidermis to the dermis. And this is just a biopsy identifying the acantholytic cells, which are these cells that have been released from each other and that kind of round up into these fried egg appearing cells. Okay, so clinical pattern, big picture, is nasal planum pinna pads, or very weird kind of pattern. So 90% in dogs are going to present with this plana pinna pad, and 10% may be a total body crusting rash or something really unusual that you have to kind of figure out. So here we have some examples, clinical examples. So this is a chow, and you can see the ulcerative erosive lesions around the eyes, on the face, but definitely the nasal planum is affected. And I made a big deal in previous slides about the haired portion of the skin, which could be folliculitis and furunculosis, versus the non-haired portion of the nose, the nasal planum, which obviously doesn't have any hair follicles and can't be a folliculitis. On the ear pinna, if this was a super itchy dog, we might think about sarcoptes and do a pinnipedal reflex. This dog is not itchy, and it actually has these lesions, pustules and vesicles and erosions on the actual flat surface flap of the ear canal. And then we're going to look at the dog's feet. And here the foot pads are actually missing. Remember, allergy is going to affect in between the foot pads. And that's a big, subtle variation from autoimmune disease, which affects the actual foot pad itself. Now, this dog's pretty obvious that the entire foot pad is sloughed off, but sometimes it's not quite this apparent clinically. This is just another dog, same thing. So we have the haired portion of the nose that we're going to worry about folliculitis and furunculosis, but we definitely have the non-haired portion of the nasal planum that's affected. So based on that, we're also then going to immediately look at the ear pinna and the foot pads to see if the pattern is consistent. This dog is a little bit less severe, less crusting, but we still have the red erosive lesions with depigmentation, and it's also going around the lips. But notice that most of the haired skin on the face seems to be non-affected. With the nose, the very first symptom that's going to develop, and especially if you can identify these kind of subtle changes, is that the normal cobblestone architecture of the nasal planum will smooth out. And you can kind of get an appreciation for that here, where the nose seems smooth, flat, and kind of shiny. So the cobblestone architecture will smooth out. Then we get a loss of pigment, and then eventually these erythematous erosions and ulcers. This is that other dog that I showed you also to point out that there's a huge clinical difference between the non-haired nasal planum and the haired portion for folliculitis furunculosis. So this dog, in fact, has demodicosis of the hair follicle, and the nasal planum is nice and normal. You can even appreciate the cobblestone architecture here. So the face is not the same thing as the nasal planum. So that's a very important differentiation. The way that we're going to diagnose the skin disease is we're going to do cytology. And if we have folliculitis caused by bacteria, Demodex, or dermatophyte, then we would treat that. But we're also going to be looking for these acantholytic cells, which are those big fried egg looking cells that have rounded up because they've been released from their adjacent cells. And that's going to be give us a really good tentative diagnosis for pemphigus with about 80% accuracy. We could do CBC serum chemistry, is usually not very helpful for dermatologic conditions unless we're worried about hypothyroidism, Cushing's, but definitely with systemic lupus, CBC and serum chemistries would be indicated because we can have kidney and bone marrow involvement. In humans, they do a lot of anti-nuclear antibody, which is a blood test. And in dogs, we can do this, but it's not very reliable. So typically, I don't go through the trouble of doing an ANA. And then the main way that we're going to diagnose this is based on the clinical pattern, but then getting skin biopsies and sending them to our dermatohistopathologist. The prognosis varies. I think there's a pretty good prognosis for the more superficial disorders, and the more deeper the disease and the bloodier the clinical symptoms, the less good prognosis we will have. In general, what I tell owners is that we have about 10% of dogs that no matter what we do, they don't respond. We have 80% of dogs that we can control the skin lesions. And then we have about another 10% of dogs that we can actually, after about 3 months, taper the medications off and get remission. The way that we're going to treat these is sort of multifactorial. And there's a table in your notes that is a list of all of the different drugs that we can use. But we want to start with most mild, with the fewest side effects, and then gradually work our way to more aggressive therapeutic options. So treatments, this is what I said. Typically, we're looking for 90% control 90% of the time. The disease normally waxes and wanes. And so one of the big questions when we have a flare-up is, are we having a flare-up of the disease, or did we develop a secondary infection typical of maybe like a bacterial pyoderma folliculitis? I showed you that dog that developed generalized demodicosis after us treating with immunosuppressive doses of steroids for too long of a period of time. And so it's important to differentiate between a disease flare and an infection flare. So this is a good example of that. This is a dog with discoid lupus erythematosus. And so here we have a very active disease where we have redness, we have crusting, swelling of the nasal planum, and just looks very, very angry. On the image on the right, it doesn't look normal. We don't have a normal pigmentation. We definitely have some atrophy and scarring, but the erythema and the crusting has resolved. And so this actually would be a dog that's being fairly well controlled with our immune modulation and immunosuppression. This is that table that I was referring to. So the treatments at the top of the table are safer and have fewer side effects than the medicines at the bottom of the table. So we're typically going to start at the top and see how the dog responds. However, if the patient has really deep bloody ulcerative lesions, we're probably going to want to jump right in and immunosuppress the dog. So treatments are usually looking at treating any secondary infections that we have, which are common. We're going to use a variety of topical and then oral medications that have very few side effects initially. If that's not sufficient, we'll move on to immunosuppressive drugs like Apoquil and glucocorticoids. I'm not a big fan of Apoquil, and I've discussed that in previous lectures. But for autoimmune disorders, especially if we're comparing to very high dose immunosuppressive steroids, I think the 10% tumor risk that we see with Apoquil is actually worth it in these patients with fairly aggressive autoimmune disorders. A couple of these treatments that are a little bit unique, omega-3 fatty acids are anti-inflammatory, the way they work with prostaglandins and leukotrienes. And they have very, very few side effects, so it's worth trying. Tetracycline niacinamide came from a human study in the 1950s and 60s, and it's about 60% at treating mild autoimmune diseases like pemphigus and discoid lupus. And then cyclosporin is FDA approved for allergy in dogs. We can use it for autoimmune disease, especially if we increase the dose. It's a dose dependent immune modulation and immunosuppression, and it tends to have fewer side effects than the Apoquel or steroids. So this is that doxycycline tetracycline with niacinamide. The niacinamide is a B vitamin. I think it's vitamin B3. And it actually is anti-inflammatory. So we think of doxycycline and tetracycline as antibiotics. They don't really work very well for staph bacteria, but they do have a nice anti-inflammatory effect with proteases and cell migration, like neutrophils, macrophages being recruited into the tissue. Relatively few side effects, and they're very cost effective. So it's not super high efficacy. We're talking about 60%. But because of their very low cost and low side effect profile, it's a really nice initial treatment option. Immunosuppressive drugs, I mentioned, cyclosporin is going to be the wimpiest immunosuppressive agent, but we can increase the dose to make it more and more immunosuppressive. Atopica and cyclovants are FDA approved for allergies in dogs, and then it's available as a generic. Apoquel and steroids are much more consistently immunosuppressive. Steroids are going to have the most number of side effects with true immunosuppression, but also hair cycling. So you get thinned hair, iatrogenic Cushing's, calcinosis cutis, demodicosis, diabetes. Apoquel doesn't have any of those typical risks that we see with steroids, but the trade-off there is that we do have a slight risk of tumor induction. Steroids, this is going to be kind of the most consistent, most reliable, but also most adverse event laden treatment. But if we need to jumpstart therapy, this is a really good option. What we want to do is we want to use very high dose immunosuppressive daily administration. And once we get 80% improvement in the clinical symptoms, we're going to taper the medications, and we're going to continue to taper, changing the dose every 2 to 3 weeks until we reach the minimum effective dose based on relapse of the symptoms. And then that'll tell us where the animal needs to be maintained. This is that dog that actually had the discoid lupus that I showed you was inactive, looking really pretty good. But this is another dog that was on long-term steroids and developed generalized folliculitis. And the three causes of folliculitis are staph pyoderma, demodicosis, and dermatophyte. Any of those could be involved here, but this dog ended up having demodicosis. Nowadays, we can treat them with some Simparica or Credelio and control the Demodex. But we definitely want to reduce our immunosuppressive treatment to allow the immune system to rebound while still controlling the autoimmune disease. So it's a really tricky balance to get this correct.